Good morning, good afternoon, and good evening to everyone who's joining this course today. I'm so happy to welcome you all to our course on gender and immunization, opportunities for action. I think there were over 100 people registered for this course from all over the world, from Nigeria to Zambia to India and Pakistan. And we know you're all very busy and really appreciate and want to make a note of the number of people that are joining us and taking the time to invest in learning about this really important topic. If we could go to the next slide, and maybe the next one. So I'd like to just take a minute to give an introduction to the Momentum Routine Immunization, Transformation, and Equity project, which developed this course. So Momentum Routine Immunization, Transformation, and Equity is a 5-year USAID project. And what you see here is our vision statement, which is to ensure that all people who are eligible for immunization from infancy throughout the life course, and particularly the underserved, marginalized, and vulnerable populations, are regularly reached with high-quality vaccination services and use them to protect their children and themselves against vaccine-preventable diseases. Although we were designed to focus on improving routine immunization, the large majority of our work over the last year or so has focused on supporting COVID vaccination, while we're also working to address all the new challenges to routine immunization that result from the pandemic. We're really pleased that there's been increasing global recognition from immunization partners, including Gavi, WHO, UNICEF, some of whom are involved in this course, about the importance of gender barriers to reaching high coverage and equitable immunization. So throughout this course, you'll learn about how to identify gender barriers in your working context, whether that's in your country or your district, and you'll learn about ways to address those barriers within that context. So I hope you'll take what you learn over the next 4 weeks and put it to good use to reduce and eliminate gender barriers to immunization. And I will hand it over to Rebecca Fields next, but before I do that, I wanted to give a big thanks to Rebecca Fields, Willow Gerber, and Sakina Kudrati for all of the work to develop this course, as well as to the Sabin Vaccine Institute for hosting this course. So thank you very much for joining. I hope you have a very productive 4 weeks together. Thank you. So Rebecca.
Great, thank you. On to the next slide, please. Right, so greetings and welcome everybody. We're delighted that you're with us today. This is going to be an exciting learning journey over the course of the next few weeks. In terms of the overall learning objectives for the course, we have set them forth as follows. Our first objective is that after participating in this course, participants will be able to describe and identify how and why gender impedes the achievement of immunization goals for coverage and equity. In other words, how gender barriers and addressing them are really on a critical pathway to achieving our goals for immunization. The second objective is that participants will be able to access the tools, the resources and support, the technical support, institutional, financial, community support, political support needed to take action to address gender-related barriers. The third objective is really to help build the capability to design and implement actions to address those gender-related barriers. In other words, going beyond merely detecting them and describing them to taking action. And the fourth objective is that participants coming out of the course will be able to assess and measure progress towards reducing gender-related obstacles to immunization. So that's a high-level overview of the learning objectives. It's how we've sort of organized the course overall, and you'll be hearing much more about that over the next few minutes and throughout this first session. Next slide, please. Over to you, Liz.
Great. Thank you so much, Rebecca, and just a warm welcome on behalf of the Boost community. I recognize a number of names from some of our other Boost courses, but for those who are joining for the first time today, welcome. The Boost community is a global network of over 3,000 immunization professionals from more than 140 countries. I know a number of you have already followed the instructions on your onboarding email and have joined us on the Boost community platform. That's where we will be hosting conversations between sessions, sharing out important course updates, including homework assignments. And we'll also be storing the sessions recordings and presentations in the resource library of that learning group. So again, if you haven't already, you can make a free account at boostcommunity.org. And then you'll be able to access the learning group throughout the duration of the course. I also have on the screen just a note about Telegram as well. So we'll be using our Telegram channel just to also send out reminders right before each session starts. Next slide. Just a few housekeeping notes for today. We do ask that you please mute yourself when not speaking to limit any background noise and feedback. You can use the reactions button at the bottom of your screen to raise your hand during the session. And that is if we have time during the Q&A portion at the end of the session. You can also, and we encourage you to engage in dialogue with your peers and workshop facilitators through the chat button, again, at the bottom of your screen, which I know a number of you have been introducing yourself. So feel free to test out that chat now. You can share your name and maybe the group that you work with. Next slide. And with that, we're going to open things up just with a poll so we can learn who's in the room today. So in a second, you'll see a pop-up on your screen, and we ask that you please select the geographic region that you are joining us from. So we will open the poll for about 30 seconds or so.
Great, thanks, Liz. We're just going to give participants a few seconds to respond to what region are you joining us from today. Great, looks like everyone is able to access. We'll just wait till we get a few more responses. Great, you all should be able to see that as a pop-up on your screen, so make sure you select your answer. And I will share the results in a few seconds. One more, two more, great. So it looks like the majority of participants today are joining us from the African region, followed by the region of the Americas at 8%, Southeast Asian region, European region at 2%, and Eastern Mediterranean region at 8%. So it looks like we have a good amount from the African region, but then across the board, pretty even, which is great to see representation from about every region we have listed here.
Great, thank you so much, MJ. I think we can go to the next slide and I will pass things over to Willow. Over to you, Willow.
Thanks very much. And I'm going to turn on my video. Good morning, good afternoon, good evening, everybody. I'd like to welcome you all, and I'm very happy to see such a great turnout. I've seen a number of people from all kinds of different places, and I'm glad that you're able to join us. I should note that this is my first time on the Boost platform, and there are a lot of moving parts. I'm sure this is not the first time for many of you, and with that, I assume everybody will be comfortable with the technology as it is, and if you have any problems, please let us know. So I'm going to briefly touch on what the expectations are for participants in this course. As you know, this is going to be a 4-course effort, and we will be meeting every Thursday for the next 4 weeks. It is 90 minutes. Each session is 90 minutes. And each week, we will be trying to cover things that we feel are of import to you. There is some flexibility. Today, we will have a lot of information straightly shared. And we expect for the next 4 weeks that you'll each participate. And between the sessions, we're going to have homework assignments. We have been very, very mindful of how busy everybody is. And so we have kept these homework assignments very short. They should not take you more than half an hour at best, but truly we have tried to make them meaningful but short to be able to respect all the other work that you're doing. And we so appreciate you taking the time to join us for this. And thirdly, we expect that you actively participate during all the sessions. Now, what we mean by active participation is just that. We want to hear from you. We want to see comments in the chat. When there's a poll or there are some questions being posed, we really want to hear from you. It's a very interesting process to really sit behind a camera and try to deliver information when you have so many people who are part of this. But we are really just a small part of what it is that is going to be this engagement. And so we need to have each of you really fully engaged and making sure that we hear from you as you need us. And also if there are things that pop up that you feel you'd like to share, please do so. And again, I want to make sure that you're comfortable with the technology. And if you're not, let us know and we will do everything in our power to be able to support you so that everybody can feel fully engaged and really, really get the most benefit from all of the work in this course and everything that we expect to, as a group, learn together. Next slide, please. So as I mentioned, this is 4 weeks and we're meeting once a week for 90 minutes. Today is the first session, June 23rd. We're going to be setting the stage of how and why gender impedes immunization coverage and equity goals. Today will be, unfortunately, very much a talking act. We will have some polls and we will expect you to answer the polls. We'd like to have you comment in the chats, but really this will be very much us imparting some resources and tools and some very general overviews of what's happening in this space. For the second session next week, which is June 30th, we're going to be really identifying the specific challenges and trying to support you in being able to make the case at all levels for the importance of gender in immunization. For the third session on July 7th, we're going to be talking about how to design and take action for the required change and really being able to implement gender within immunization programs and making sure that you have a comfort level in order to do so. There are many requirements now of gender integration in immunization programs, and we want to make sure that you know how to get the resources, how to use them to the fullest capacity, and really feel comfortable in this new area. And then on July 14th, which is our last session, we want to talk about how to assess whether or not you've made progress. And again, the emphasis is really on all of us learning together. In fact, gender and immunization is really quite a new area. One of the things that we are benefiting from is other development areas that have implemented gender. So we actually have a lot to learn from those other areas that have done this before. And we expect that there will be some element of what, for lack of a better term, of leapfrogging and being able to really gain a lot of momentum early on because of everything that has come before. Next slide, please. So today, this is our full agenda. I'm not going to go through each one, but just know that as we progress, we will have a couple of speakers, and then I'll also go over a couple of significant points around how to recognize gender-related barriers to routine immunization. And then we'll have some exercises. And then at the end, we're going to do a quick wrap up and we'll talk about today's takeaways, and I'll briefly go over the homework. Next slide, please. All right. So as I mentioned, a lot has come before in terms of gender integration in various health and development areas. And I know that some of this, many of you may already know. What I'd like to point out is that we don't want to be presumptuous of where people are beginning. And for those of you who may already have either gone through some gender training or really have your own learning around gender in development, we want to make sure that we can go back to some very, very basic points. And so as I mentioned, I think many of you probably already know this, but we're going to cover these very briefly. Next slide, please. So the first thing to keep in mind is that when we talk about gender, we're not talking about sex. So sex and gender are two different things. Sex is biological and gender is social. And I'm not going to read these points. These are things that you'll have access to the slides later, and you can go over them in more detail if you'd like to. But the point being, gender is a social construct. One of the things to keep in mind is, unlike a lot of other development areas, we're all born into a gendered space. So it's not the same kind of thing in your work learning in a technical area where you're really starting essentially from a new perspective. Because you were born into a society that already had gendered systems in place, everybody is coming into this space with their own thoughts. Some might call it some baggage, some experiences already. And that actually is important to recognize, and because it will inform how you go about the work in gender in immunization. So because gender is a learned construct, it can also be unlearned and relearned. And one of the things that's very important in recognizing this is that as you progress in your programs, being able to be really mindful of what has been constructed in terms of roles and norms and behaviors is really how people move around in the world. And we need to make sure that for immunization, everybody has equal access to the life-saving vaccinations that are available. Next slide, please. So we are covering gender with some touch points on intersectionality. I'm sure you've all heard this term before, and it just means that gender doesn't operate alone. It operates in other areas that all fit together. And depending on what framework you're looking at, they can include race and ethnicity, class, nationality, sexual orientation, abilities, and others. So we're using this one, which is adopted by the UN and WHO, and we will touch on it as we get along further into the course. Next slide, please. So what I'd like to do now is to welcome Jean Monroe. Jean is the Senior Manager for Gender at Gavi, the Vaccine Alliance. So she's going to discuss how to reduce barriers and how that aligns with Gavi's goals for equity and the ways in which Gavi is promoting gender equity through its strategies. So I am going to ask Liz to please begin the presentation. And I want to make sure that you're aware, we actually pre-recorded Jean's presentation, and we do that for a number of reasons. Most importantly, so that it's easier to really present the information, but Jean's here with us on the live chat, and she'll speak to this after this video. Thanks very much.
I'm very pleased to be able to share with you Gavi's commitment to gender equity in programming and to describe to you what that looks like in terms of steps within the Secretariat, our process for designing grant applications, as well as the types of interventions that we're now seeing in countries. I'm sure many of you have already seen the new Gavi 5.0 strategy with a vision to leave no one behind with immunization. What I'd like to bring to your attention here is that gender is central to the vision. It is elevated as a principle, and it's also core to our goal on equity in immunization. We have a policy which has a goal to identify and overcome gender-related barriers to reach zero dose and under-immunized children, individuals, and communities. And it encompasses three main areas of work. The first is to identify and address the underlying gender-related barriers faced specifically by caregivers, health workers, and adolescents. It encourages and advocates for women and girls' full and equal participation in decision-making related to health programming and well-being, and in the specific pockets where they exist, to overcome differences in immunization coverage between girls and boys. Within the Secretariat, we've taken a number of steps to mainstream across our practices. The first is to galvanize our support and to enhance our capacity and understanding and skills. And we've done this through providing informal learning sessions, webinars, and sharing stories on gender and immunization. We've also developed formal training courses. So one we're developing with George Washington University through the Gender Pro program. And we've developed a specific immunization track for that course. And there'll be a short course, which is about a month long, and a long course. And these are intended for Gavi Secretariat and Alliance partners. We've also partnered with Bull City Learning to increase the number of videos that they have available for health workers on gender and immunization, as well as we've developed 2 courses with them, which will be online through the Immunization Academy, one for health workers and one for supervisors, again, addressing the gender-related barriers in immunization programming. The second step we've taken is to increase our coordination across the Alliance to ensure that we have more complementary programs and to build on each other's programming guidance and lessons learned. Our third approach is refining our approach and guidance. And we've done this by developing guidance to have an inclusive and diverse full portfolio planning process. So that's the process that Gavi uses to develop grant applications. And we're also promoting the use of participatory approaches such as human-centered design, which we've seen as a really effective way to bring out communities' identification of gender-related barriers. Our zero-dose strategy integrates gender-specific considerations, and we've developed program funding guidance, which includes very practical gender-specific interventions at all the different stages of an immunization program. We've set expectations for gender integration in our applications, monitoring, and reporting systems. So we have guiding questions throughout our grant application. That means from our situation analysis to the theory of change, to the work plan, to the M&L plan, as well as the budget. And this is the first time that we've asked countries to mark to what degree activities will address gender-related barriers, and they'll be marking that in the budget. We also have a new fund available to support testing and sharing of information around gender responsive and transformative approaches. And this is a way to build up evidence and understanding around these areas. So that's what's happening within the Secretariat. At the country level, we're supporting countries to use the IRMA framework. That's the Identify, Reach, Measure, and Monitor and Advocate framework. So the first step there is to help countries identify where, who, and why they're zero-dose children. And we've integrated gender in there by asking the question, what are the barriers faced by caregivers, health workers, and adolescents? On the reach side, this is about tailoring strategies that will be sustainable, and they'll address both the supply and demand side within the immunization program. And there we've also supported countries to identify the gender-related barriers and ensure that they're addressed through specific interventions. The next step is to measure and monitor. And this we're moving forward by ensuring that the monitoring is happening on a much more rapid pace than has been done before. And we're encouraging sex and gender-related data to be measured and monitored. And then, of course, on the advocacy side, that's the step to use evidence to make a case for political attention and resources. And for gender, we want to ensure there that we're building the evidence and we're strengthening the political will towards addressing gender barriers. So if we take that framework and we look at zero-dose communities, we often see high zero-dose populations in urban slums, in remote communities, and populations in conflict settings. And if we do a gender analysis, we can find different types of gender dimensions in those different communities. And again, this is an important step that we're doing with countries to ensure that they have identified what the barriers are. Another really effective way that we've helped identify what the barriers are is using something called the behavior and social driver framework. And this really asks the question, what drives uptake? And you'll see on the left-hand side, we ask people what they think and feel around vaccine benefits and safety, and also what the social processes are in terms of their decisions around going for vaccinations. And it also looks at motivation, so families' intention to get the vaccines for their children. And although this is out of the power of caregivers, we also look at the practical issues that they face to access the vaccines. So we see these as core steps that an individual will take and have to go through in order to get their children vaccinated. And if we look at the social processes, there's some key questions that we've learned have given us really important information to help design effective immunization programming. So for example, using this framework, there are survey questions which ask about decision autonomy. And it asks, in your family, who has the final say about whether a child will be vaccinated? Or there's a question about travel autonomy. So if it was time, would you need permission to take your child to the clinic? And these are questions which we have not been asking in the past, and which really give us information that is key to designing a program which will effectively reach the communities, and particularly the communities that we continue to miss. So moving forward on the question around who has the final say about vaccinating your child, I'm just sharing with you a graph that compares the responses over a number of countries. And you'll see here, the top country here is Uganda. And you'll see the yellow means that both of the parents have final say. The green means the mother has final say. The purple is the father, red is the grandmother, and blue is an other caregiver. Now, in the past, we've just assumed that a mother would have the final say, as she's the one who is normally in charge of children. So asking these questions gives us really relevant information for how we would change who we reach out to, how we message about it, and it helps questions our assumptions. So that's just one step that we're taking or working with countries to use this framework to help get more detailed information for more effective programming. And there's a number of other interventions, based on that information, we've developed other gender responsive interventions which are addressing different barriers. So again, along the lines of who has the final decision, we're looking at different approaches that promote the involvement of fathers in immunization. So we're working in Zambia, Mozambique, Togo, Afghanistan to promote involvement of fathers. In India, we are integrating services and as well having a duo health ambassador. So both men and women health ambassadors work with parents, so both mothers and fathers, to improve fathers' involvement in immunization services. In Somalia, to overcome the barrier of few women being involved in vaccination and many caregivers not wanting to access vaccination services by men. There's a promotion of female vaccinators in Somalia, as well as Afghanistan. And I think there's one barrier that many people around the world face, and that's just the clinic hours being not open at the time that is accommodates working parents. So in Bangladesh, they're extending the clinic hours, and we're watching that to see how well that will actually address some of the barriers that working parents, particularly women, face when they're trying to access the services. So these are just some examples of areas that we're trying through Gavi programming. And we're measuring the results of those. But I'd be happy to answer any questions during the Q&A about other steps that Gavi is taking to promote gender equity across its immunization programming. Thank you.
Thanks very much, Jean. Next slide, please. So next up is Rebecca Fields, who is our technical lead on the project. Rebecca, over to you.
Great, thank you very much. And I have to say, I'm so impressed by the questions that are already coming up in the chat box. You know, some of these issues about autonomy, about access, about competing priorities that mothers and female caregivers face, and about the need for localized solutions that respond to the different situations. These are such important points that we will definitely want to take up and discuss more over the course of this session and later sessions. Next slide, please. Okay, so I'm just going to take a few minutes to highlight that for those of us participating in this course, there really is this groundswell of support for recognizing and addressing gender-related barriers to immunization and equity in immunization. And therefore, we're not really going it alone at any level. There's a great deal of forthcoming support. Jean Monroe just mentioned this with regard to Gavi changing its processes for applications to more fully recognize gender-related issues. So I'm just going to go through a few types of support that are available, primarily technical support. Next slide, please. Right, so within the global immunization community, there really is this growing recognition about gender-related barriers as impediments on a pathway to achieving high and equitable coverage for everybody. So we've just heard from Gavi about the types of support that they are providing and integrating it into their application processes, their monitoring and evaluation, the development of theories of change, and so forth. WHO has also taken a prominent role in recognizing how gender barriers affect different aspects of equity for immunization, improving equity for immunization. UNICEF, for its part, a few years ago in 2018, wrote a paper on this topic that was really seminal in creating broader recognition of gender as an issue that needs to be addressed in the IA 2030, the Immunization Agenda 2030, and in the Gavi 5.0 strategy for 2020 through 2025. The Global Polio Eradication Initiative has likewise incorporated gender into pretty much all that it is doing. Certainly bilateral partners such as USAID have made gender an essential, important part of its work. That is certainly the case for our project, Momentum Routine Immunization Transformation and Equity, where we were actually required to develop and implement a gender strategy, which we are quite enthusiastic to do. And certainly gender has been prominent in the deliberations so far of the zero-dose community of practice. And if you haven't become a member of that practice yet, this is easy to do. We've provided the link for registering for that community of practice here. Next slide, please. Right, so there are increasing numbers of technical resources that really can help people at various levels to support and integrate gender-sensitive programming into their work for immunization. I'm just listing a few of these resources here. This is not an exhaustive list, but a few that I'd like to bring your attention to. So WHO recently created a web page on gender and immunization that itself contains several resources. Jean just spoke about the Gavi gender policy and revised application materials. You can access this information at this link provided here. UNICEF has certainly been very active in the space of gender and immunization. And just a couple of documents to refer to here are an excellent document that the Regional Office for South Asia of UNICEF put together in 2019, Immunization and Gender, a practical guide to integrate a gender lens into immunization programs. And at the moment, UNICEF is developing a new document that they're calling Gender, Immunization and Equity, a learning and solutions tool. This is really quite a comprehensive tool. They're just putting sort of the final design touches on it now, and it should be forthcoming soon. The Global Polio Eradication Initiative created its own gender strategy, and actually just yesterday posted new training and sensitization materials on their website on the topic of gender and polio eradication. These can be found in their section on polio surveillance. The zero-dose community of practice, which I mentioned a moment ago, just over the past 2 weeks featured webinars on gender-related social and structural barriers to immunization. And you can find the links to those webinars on that zero-dose community of practice website if you go and register there. And as Jean Monroe mentioned, the Immunization Academy Watch, run by Bull City Learning, has been supported by Gavi to develop a series of learning videos in which gender now figures prominently. Some of them are specifically about gender, and some of those new videos have incorporated gender into some existing areas of work that they had already developed videos for. Finally, not specific to any one group, there are a number of important multi-agency tools and materials. Let's go on to the next slide, please. And I'm just going to talk about a few of them here. On the left-hand side, you can see tools and practical guidance for achieving high uptake. This is as part of the behavioral and social drivers of vaccination approach that Jean Monroe mentioned a few minutes ago. A very important document that has just been put out by WHO, UNICEF, and Gavi is called Why Gender Matters. This document recognizes that if you look at the entire series of strategic priority areas for the Immunization Agenda 2030, you won't see that there is just one strategic priority area on gender. Rather, it pervades, it is addressed in all of the different strategic priority areas. And this document, Why Gender Matters, brings out how gender considerations can be brought into each of the strategic priority areas of the Immunization Agenda 2030. We'll be talking more about that later. Next, WHO has developed a guide for conducting a situation analysis for immunization program performance. This situation analysis will then inform the development of the type of national immunization strategy for which you see guidelines on the right-hand side of this page. And I'll come back to that in just a moment. And as I'm sure many of you are aware, national immunization strategies are multi-year strategies for immunization. Currently, a number of countries are in the process of developing them. And you'll see the links for all of these documents down below here. Next slide, please. Right. So in the process of developing national immunization strategies, this slide shows how something came out a little bit funky with this slide at the top. But this slide shows how addressing gender is integral to every single part of developing that national immunization strategy. This first little icon up here should have the word preparation next to it. I'm not sure why it doesn't. We see that gender is then incorporated into the situation analysis step, into the strategy development, into the monitoring and evaluation framework, into estimating the resources that are needed, into then talking about the budget and trying to secure the resources for implementing the strategy, and finally for obtaining approval and endorsement. So you'll see all of that showing up within the National Immunization Strategy Guidance. Next slide, please. Why gender matters, I mentioned this a moment ago. We'll be talking about this more later, so I'm just going to move on quickly from this one. Next slide, please. Right, with regard to the situation analysis for immunization program performance, as I mentioned, this document is forthcoming. There had been an earlier version of it in which it was then recognized that actually the gender-related issues were not sufficiently recognized and addressed. So at the moment, this document is undergoing revision to actively incorporate gender-related questions and issues into it. This document will be available probably by the middle of this summer, so within the next 2 months. Next slide, please. So finally, this is my last slide. I just want to say that during this course, throughout this course, we're going to be introducing opportunities to really become familiar with these tools and how to use them so that we can all see how they can serve us as well. So thank you very much. And on to the next slide, I think, which is just the final one. Yes, on to the next one. Thank you. So over to you, Willow.
Thanks very much, both to Jean and to Rebecca. I want to be mindful that we are paying close attention to all of the comments and the questions that are coming in. Since we're live, it's a little difficult for us to address each one of the questions in live time, but we will be paying very, very, very close attention to each of the questions at the end of the session and making sure that we address them appropriately. So if we don't get to your specific question during our conversation here, know that we will still address it either on the platform or as we continue this conversation in the next session. So relative to what Rebecca and Jean went over, there are a lot of resources out there right now that address gender in immunization. And some of them are very long, some of them are not so long. Some of them actually provide a very, very good step-by-step process of how to go about implementing gender in your program. So one of the things that I want to speak to very briefly here is frameworks. There are now a number of frameworks that address gender and specifically gender in immunization. A framework is really just a way of organizing information, as you all know. How you choose to organize the information really depends on your relevant context and your experience. Sometimes it also depends on the time available for you to do this. A number of frameworks speak to gender analysis specifically, and some of you may have the occasion to do that. We will not be addressing specific gender analysis in this session, but we do expect people to be able to have a familiarity and really be fluent in a way to assess gender within their programs. So it's really just a way of thinking of how you'll organize the information that you need to gather to know whether or not the gender issues how relevant they are to your context, and what to do about them. Next slide, please. So first and foremost, we want to talk about what's actually needed to address gender barriers. So I want to attribute this to Shubu Jalal from UNICEF. This is actually the way she's organized this bit, which I think is very important to consider. So as I mentioned before, gender is really part of a system, and it's in every kind of social system that people are a part of. Ours in particular, the health system and the specific immunization system, is one that's very dynamic and that's ever changing. But what is it that we actually need to talk about in terms of gender barriers for immunization? So there are individual considerations. So mothers, fathers, individual people within a household. And we want to make sure that caregivers, what we need is to have caregivers who know to, who want to, and who can vaccinate their families. Then at the next level, which is community, what we need is a community that accepts and promotes vaccination. And that involves health facilities, the next level. And at the health facility, we need a health workforce that delivers effective vaccines and builds trust. And I think that that's a very key issue, is the relative importance of building trust. So the health facility building trust with the community so that then individuals can take action. Then we also need equitable systems that secure and regulate vaccination. That also is an extremely important category for building trust for the health facility. And then overall, we need relevant policies in place, which include laws on the books and other institutional policies. Next slide. So regardless of what framework people are using, and many global organizations are using different frameworks, but each one really is very similar to the next. I know that sometimes this can be confusing for those who are really on the front lines who are trying to do the work, because a group will come with a new framework and say, do it this way. And people need to learn the framework and then try to adapt. But when we talk about gender and immunization, and really gender overall, there are some very standard domains by which people organize the information around gender. So regardless of the framework, these are the areas that the framework generally touches on. The first, as mentioned, laws, policies, regulations, and institutional practices, cultural norms and beliefs, gender roles, responsibilities, and time use. Now, I capitalized time here, and I noticed as Jean and Rebecca were speaking that a number of you actually in the comment chat talked about the issue of time, and the caregivers are really, really pressed for time. That's a very significant domain area that's relevant to gender. And that presents huge disparities in terms of how people use their time. And in general, not always, but in general, caregivers have so little time, and they are expected and required, because of these gender norms and responsibilities, to be multitasking beyond belief. So keeping mindful of that time use within the gender domains is really important. And how at each one of those levels would you address really being able to support a caregiver who has very little time, and you have to be efficient and you have to be effective and really help them make use of the time that they have, because they are prioritizing that time to be able to get to the clinic or to be able to have somebody into the home to vaccinate the family. Then access to and control over assets and resources, extremely important for gender in immunization. And then the patterns of power and decision-making. A number of you already in the comment sections in the chat talked about how caregivers really don't always have permission to get the children vaccinated. And that is one thing that, as I said, because gender is a social construct and it's learned, that there are some elements around decision-making that need to be relearned. And relearned in a way that is supportive of everybody in the family. So I want to be mindful that gender is not just about women, that gender is really about everybody, and making people's time use better and really supporting effective decision-making across the board supports everybody, everybody in the family and then the community. Next slide, please. So if any of you have had an opportunity to go through some gender training, you may very well have seen this, the gender integration continuum. Generally, it's noted as an IGWG framework. It was actually a framework that started early on during the HIV/AIDS epidemic. And the way it is distributing the thinking process and the information is recognizing that if people are not being really conscious about putting gender as part of their planning process, they are what is termed gender blind. And what that means is that they're not purposely trying to undermine women or men, but they aren't necessarily paying attention to all of the variables that go into women and men trying to access services. So that's gender blind. We can't be gender blind anymore. We have to, at the very least, be gender aware. And that's very important as you're developing your programs and going through all the steps necessary to implement gender, that you're actually paying very close attention and being explicit about saying, we think gender is important, we know it will help us with our outcomes, and so we're going to prioritize it. And I think one of the things that has resonated throughout conversations now, certainly at the global and the national level, is that making gender a priority also means providing resources for it. And so that's where we're at. We are expecting everybody to be gender aware. Now, within the issue of being gender aware, it's sort of like stoplights. So there's red, yellow, and green. What we're trying to do in all of our efforts is really move towards being transformative. But transformative really speaks to changing harmful norms. And anything at the normative level is very hard to do. It also takes a lot of time. So don't get discouraged. If you feel that you've tried to do something within your own context and you feel like you're not getting there, you have to be tenacious, recognizing that real transformation takes time. So keep at it. Now, one of the things that is really important to pay attention to is maybe you implement something that you think is really going to help in terms of gender inclusion within your program. So if you aren't being very careful, sometimes you can be what's considered exploitative. So I can give you a very good example. And I think a number of the participants during the application process, I think you remember there was actually quite a long, there was a real long questionnaire, and there were some open-ended questions, and really a number of you said with enthusiasm, we are trying to be really forward-thinking and supporting male engagement in immunization. And so if dads show up at the clinic, they get priority. Now, that as on the surface, sounds like it would be a great idea because we actually do want men to be more involved in supporting immunization and the health of their families. But if a man shows up with the children at the clinic and there's already a really long line out the door of women who've been there for countless hours sometimes, and a gentleman shows up and he gets moved to the front of the line, that actually reinforces standard gender discrimination. So you think that it might actually get you ahead of, getting men into the clinic with their children and getting them vaccinated. But in terms of the long view, it's reinforcing difficult norms, and it's not really supporting the idea of transformation. So here's an example of a transformative effort. Let's say that there's a school education and health program, and it's designed to increase HPV rates. So one of the things that would be effective and be transformational is if those folks developing the program actually conducted a baseline assessment and identified where teachers and their students were in terms of their knowledge and their attitudes around gender dynamics, sometimes gender-based violence, and health and well-being. And then designing a program that actually uses participatory activities with boys and girls, and really explore issues related to gender and relationships, reproductive health, interpersonal communication skills, etc. And that's very transformative because it's taking the long view. Something that would be accommodating would be, for example, let's say if you're in an area where women have lower levels of education, and a project develops an immunization communication material kit that is tailored individually for educated and then less educated groups, and they use different illustrations and less complex language, etc. That's very good. That's actually very, very good. But it's accommodating. It's not transformative. And some of you may feel that in your role, you really don't have an opportunity to be transformative. But I think everybody does at some level. And as long as you are mindful in the design of your programs that what you're really trying to do is to transform things to make it easier for families to be healthy and to get everybody vaccinated, and being mindful of how you proceed in that is really the goal. Next slide. All right, so in keeping with the idea of accommodating, transformative, exploitative, let's think about two examples, very common immunization challenges. The first would be vaccine stockouts. And then the next one are vaccine cards. And frequently vaccine card stockouts mean that women show up at the clinic and can't have a card to take back with them. So I'd like you to think for a moment about this challenge and what that actually means if you're considering it from a gender perspective. So think about the gender lens in this challenge, and what would that look like? And you can put some responses in the chat. So in general, when we talk about vaccine stockouts, people think, oh, that's a logistics issue. And it is. But with the gender lens, it's beyond just a logistics issue. I'll give you a couple of seconds to think about it and to put some remarks in there. Right, it is poor planning. It is. And from a gender perspective, how would having vaccine stockouts affect the caregiver? Every issue the caregiver does doubles. Exactly, like taking permission again. Yeah, and they'll incur higher transportation costs because they have to go back again. Exactly, they may not have funds again, right? Next slide. So considering this with a gender lens, when we talk about vaccine stockouts, it would mean that the caregiver, who is in general female, they have to return for extra visits. That means it's going to have higher expenses and more time away from the other duties that they're required to do to be able to get the child fully vaccinated. So a vaccine stockout isn't just a logistics problem with a gender lens. It has to take all of these other issues into consideration. Now, in terms of vaccine card stockouts, again, the female caregiver, who's generally, the mom, wouldn't have the necessary information to be able to go back to her household and share with her partner about when they have to return for the next vaccination and even how many times and what other vaccines are expected. And this isn't written here, but the other issue around not vaccination card stockouts, but just vaccination cards. As caregivers are multitasking, what if a mom finally gets the permission to take the child to the clinic, gets the funds needed to be able to take the transportation? Who knows how long it will take them to get there? And then they show up at the clinic, but they don't have the vaccination card. Then what happens? I think depending on who they run into, who their service provider is at the clinic, sometimes it can go pretty badly. And exactly. And they do lose trust. They lose trust in the vaccination process because they really did everything that they could to be mindful to get there, and they didn't have the vaccination card. And I know that this happens a lot. Next slide, please. So in terms of other frameworks, this is a framework from IA 2030 with WHO, looking at gender barriers and approaches to achieve IA 2030 goals. It's actually a very good framework. It is part of one of the resources that Rebecca mentioned, which is called Why Gender Matters. There are links to that, and I hope that you do have an opportunity to take a look at it. It's a very, very good resource. They set up their information looking at structural causes, and then the inputs and the outcomes. And they also have it set up, as I mentioned before, at the household level, the community level, the health facility level, and laws and policies. So one of the things that I hope you take the opportunity to look at, and we won't go through each one now, but really take some close attention to what they list as structural causes. So these are a little more granular than the others that I had mentioned previously, but they still touch on those same areas. So they touch on the issue of power and resources and issues of access at the individual household level. And then they talk about gender norms and roles. And they do have a bullet point on the lack of men's involvement in care. And at the community level, again, where they, where they say women's lack of voice, it could also be termed women's lack of agency. So a woman really not having an opportunity to make her own decisions, either at the individual level or certainly at the community level. And again, back to gender norms, and limited mobility, which we see very frequently in a number of these frameworks. And then the lack of supportive measures at the community level. And I think lack of supportive measures is not just the community level, but those would really run across the health facility level and laws and policies. So I want to say something very, very quickly. When I first started doing gender, I was much younger, very, very young. And I wanted to really be active and see things happening very quickly. And so I thought, well, laws and policies, okay, that's maybe it's important, but what I want to do is really something at the front line and be actively involved. And then I had the opportunity to work with somebody who really was an expert in laws and policies around gender. And one of the things that she taught me, which I remember so distinctly, is that you have to have all these laws and policies in place, otherwise you have no accountability. And so for those of you who are involved at the law and policy level, making sure that those laws and policies are in place and that there is accountability. And there's very frequently in the gender space, there's very frequently a gap between what laws and policies exist and how they get implemented. And sometimes it is a huge gap. And one of the things to start with is to make sure that people are aware of the laws and the policies that are in place, and then figuring out how to really solve some of those gaps. Next slide, please. So in this same resource of Why Gender Matters, they divide their barriers in these 5 categories. So the first one is poor quality services and negative health provider attitudes. And as this slide came up, I saw a number of people commenting around that specifically, and that depending on what clinic, what facility people go to, sometimes it's a very, very challenging experience. And there are many reasons for that. And one of the things that I think we need to be mindful of is, in general, the healthcare is primarily women. So healthcare providers in general are primarily women. Health leadership is not. So I think the global numbers are 70% of the health workforce are women, but only about 25% of them are within leadership positions of those systems. Now, if 70% of the global healthcare workforce are women, and women are showing up at these facilities to be cared for, you have to also be mindful that the women who are working in these facilities as women are also facing these same challenges that the female clients are facing. So the issue of time use and the issue of changing expectations and always having to meet higher and higher expectations, and not always being supported in doing so, not always having the appropriate resources to doing so, is very real. So we recognize that clients who come for the services are really doing their best to get there and to do what they should do. And we also really want to recognize that the service providers, who are in general female, not always, but who are in general female in many of these circumstances, that they also, I think they are also doing their best, and that it's really a systems issue to be able to support them and allow them to enjoy what they're doing, because their work is really important. Then the second category is the low education level and health literacy. Excuse me. That's something that some people feel that at their level, there's nothing they can do about it. But I think that there are things that can be done, and we'll address that in some of the coursework further on. Then limited autonomy in decision-making and household dynamics. That's something that you will find in almost every one of these frameworks, and for good reason. Then lack of access and control over resources and mobility. And then finally, high prevalence of gender-based violence and harmful practices such as son preference, child marriage, levirate marriage. For those of you who aren't familiar with levirate marriage, it's in many countries, even if a wife has been integral in working and accumulating assets during their marriage, if her husband dies, it's very common that she loses everything. She loses her home, she loses all of her assets, and she may be expected to marry the brother of her husband or a close relative of her husband's. And though many countries have technically outlawed it, these are still practices that go on. So this is how Why Gender Matters document sets up their information around categories of gender-related barriers. Next slide, please. So you've all been doing this as I've been speaking, and I've tried to look and to see all of your comments. I haven't had an opportunity to do so as much as I will be able to do so after the course. But for those of you who have not yet put anything in the chat box, this is your opportunity. Please take a moment and let us know what kind of gender-related barriers in immunization you've observed. I'll give you about a minute to do that. Lack of education, lack of access, decision-making by male individuals. Preference of male child. Fear of vaccines, that's very real. Self-confidence, culture's weight. Health workers who have low education and vaccine immunization information. Security compromises, very real. Cultural and religious barriers. Long distance, men not accessing vaccination services, preference for female health workers, financial dependence, poverty. Yeah. Thank you. Thanks for everybody who's put in some of those. And I think when we first went live on the course, somebody who put in the comment, I wrote it down, they had said, there's a dire need for the caregiver to fend for food for the family. They just don't have time. That's going back to the issue of time use that we mentioned. And I think that that's one of the key points as you're addressing your programs, is being mindful of how much time it takes, and that this is a preventive service. And a lot of times people who are perhaps in a crisis situation or in far-flung areas, or who are dealing with really difficult situations in their own household, even being able to take the time to acknowledge that vaccine is preventative, and that doing it now means that they gain opportunities later in terms of health. Sometimes when people are dealing with too much, they don't think ahead. They can't think ahead, and it doesn't mean that if they finally make it to the clinic that they should, that they should be mistreated because maybe they missed a vaccination and they're playing catch up. But this is something always to be mindful of. Thanks very much for everybody's comments. We're going to take a close look at those after the course, and we'll organize them and talk about some of those in the next session. Next slide. So these are some of the common gender-related barriers to vaccination that is in the Gavi resource document. So lack of information and awareness by caregivers, the division of labor in the household, and in general, men don't really think of immunization and vaccine services as being part of their domain that they need to be responsible for. Low socioeconomic status is very significant across all health areas, not just immunization. Religious practices or cultural values that might prevent people from seeking these services, the long distances, the long wait times, and then once again, the negative attitudes. So there's very significant recognition about what some of the problems are. Next slide, please. So now we're going to consider a couple of scenarios, and we're going to ask you to fill out a poll. We're going to go back to those 5 gender-related barrier areas that were in the IA 2030 document of why gender matters. And apart from the 5 that we'll have listed, we also have an other category. And if you don't feel that those 5 capture what you find in your own context, then you're welcome to add an other category. So let's get ready for the vote. Next slide. So here's the first scenario. So a father doesn't want his infant child to return for further immunizations because after their first shot, they had a fever and they cried a lot. So which gender-related barrier do you think applies to this situation? Now, are all of you seeing the same screen that I have, which is actually showing these results as they come up? I believe you are, correct?
No, so we'll project the slide in just a moment when we get to about 75%.
Okay, great, thank you.
Great. Great, I think we can go ahead and share the slide then.
Okay. So these are the results that you came up with. Low education literacy and low education and health literacy was overwhelmingly what you folks felt that this related to. And then some limited autonomy and decision-making at the household level. Then the next would be poor quality services and negative health provider attitudes. So on the surface, if a dad is saying, no, you can't take our child to get immunized again because they weren't doing well after the last immunization, it is definitely a health literacy issue, for sure. But part of it really relates to the quality of service that the mother may be getting, if it's the mother indeed who's taking the child, which it normally is, that they may be getting from the health provider, because they aren't able to share with the father to say, well, no, that's very normal. That's not unexpected. And it's not a problem. These are just sort of issues that happen with many infants when they get their vaccines. So it's both health literacy in terms of what to expect during the immunization process, but it's really very much about service quality, because the clients who show up need to have that information so that they can take it back to the household and make sure that the fathers understand that. And again, the limited autonomy means who has the final say. So that's correct. If the father's saying no and he's got the final say, then where's the wiggle room to be able to have a conversation around that? Thanks very much. Okay, next slide, please. So for this next scenario, we're talking about a house-to-house immunization campaign, and a female vaccinator arrives at the home, but the mom doesn't have the permission to vaccinate her child. So what scenario, what gender-related barrier does this relate to? And I'll give everybody a couple of seconds to be able to make their choice. Liz, are we at 75% yet?
I think just about. Maybe we can go ahead and share the screen.
Okay. Oh, the only option I have is to stop sharing. I can also certainly say them out loud if people aren't being able to see what the results are. So overwhelmingly, 73% of you said that it was limited autonomy in decision-making. And then the next at 13%, which is a big drop, is again, low education level and health literacy. And then the next would be lack of access and control over resources and mobility. And then at 4%, poor quality services and negative health provider attitudes. And then a couple of you mentioned high prevalence of GBV and then other. So this one in particular also touches on a number of them. And they're ones that you've already talked about. So yes, this is about limited autonomy and decision-making over household dynamics. And it does definitely touch on health literacy. So one of the things that was interesting in some of the polio campaigns, house campaigns, when they realized that some women weren't allowed to have men into the home. So during these campaigns, what they did is they worked really hard to get more female vaccinators. And they thought, now we've got it, now it'll go great. We'll be able to help our community. But when the female vaccinators showed up at the home, it was the same dilemma that they didn't have access to be able to vaccinate the children, because if the father wasn't home, the mother had no right to give permission for the vaccination. So there are multiple elements that go along these gender barriers, and we have to be mindful of that. Next question, please. So very quickly, we're going to talk about what in your context you find, again, according to these 5, are what you deal with most. If these don't speak to you precisely, you can write in your own other. And we're almost at time, so we're going to only do this very, very quickly. So Liz, if you could get the poll going. And for anybody who chooses other than these 5, please insert whatever you think would be another gender-related barrier that wouldn't fall into these categories, but which you've observed, and just put it into the chat box as other, please.
Great, and I think Addison has just launched the poll.
Great, thank you. These are interesting results, and we'll address some of these in the later sessions. To be mindful of your time, I'd like to go on to the wrap up, please. Next slide. So we are almost at time. As I mentioned earlier today, this was very much a lot of talking at. In the next sessions, we'll have more opportunity to hear from you directly and to really go over some of the resources and the steps that you're expected to take to be able to implement gender in your programs. I want to very quickly, next slide, please show the following key takeaways from today's session, which I hope you've also learned. So gender-related barriers and gender inequality can prevent people from getting vaccinated. And we know that. And the goal is to really have everybody have the same chances and opportunities to be able to access and benefit from immunization services. Now there's a significant focus on gender immunization programs. And there are lots of tools and resources out there to support this focus. The attention to gender-related issues in immunization programs really go beyond focusing on the coverage discrepancies between girls and boys. And in the past, when people referred to gender and immunization, a lot of people said, well, we don't have a gender problem, because really for routine immunization, boys and girls, for the most part, there are a couple, outliers, but for the most part, boys and girls are having the same coverage rates. But that's part of it, but that's not what we're really talking about when we're addressing gender and immunization now with this more significant focus. Gender is a social construct. It's learned. And so it can be relearned to be really something that is supportive and benefits everybody. And it's systemic, and it really operates in an interplay between the individual, the household, the community, and systems factors. And then lastly, the different ways of organizing it according to a variety of frameworks that they almost all will and should touch on. Legal rights and status, cultural norms, perceptions, and beliefs, roles, responsibilities, and time use, access and control over resources, and then patterns of power and decision-making. Next slide, please. Here's your homework. As I mentioned, we've made it very simple. We'd like you to please watch this brand new great video that's about just under 6 minutes long from Bull City Learning, and it's called Understanding Gender-Related Barriers to Immunization. And then we'd like for you again to identify 3 gender-related barriers from your own context, and then compose 3 to 5 sentences. If you don't want to write sentences, you can just do bullet points. But we'd like to recognize what barriers you feel that you're facing, and then prioritize one that you will use and think about throughout the rest of the course. And for that, we would like you to just take certainly not more than 30 minutes max to be able to have either bullet points or 3 to 5 sentences around what that gender barrier is. We expect that you submit it by close of business on Monday, which is June 27th. And if you have any questions or concerns, or would just like to have some feedback as you're doing this, please get in touch with us. And with that, next slide, please. Liz, if you would like to address this, there are a couple things that we want to make sure you do also. Go ahead, Liz.
Great, thanks so much, Willow. And I won't take too much time. I put all of these links in the chat, but we do ask that you take our post-session survey so we can get feedback on today's session and improve for our future sessions. Again, the presentation and recording will be available in the Boost Learning group. So if you haven't already, please join the Boost community platform, and I've listed the link direct to the learning group. And then last but not least, you can join our Telegram channel for timely reminders about sessions. And again, the link is included in the chat. You'll also be receiving all these links via email in a couple days, so be sure to be on the lookout for that in your inbox. I think that's it from my side. Anything else, Willow, from you?
I don't think so. I would like to thank everybody for being here. We had over 100 people. And again, this is now a really wonderful community, and we hope that you'll take advantage of each other and recognizing that everybody has significant information and experience to share. And I promise that the next session won't just be me talking at you. So looking forward to seeing you in a week. Please stay in touch, and we will do so as well. Thank you, everybody, so much. And I hope you have a great weekend. Bye-bye.